the management of the diabetic foot. Welcome to our podcast. Today, we are diving into one of the most critical yet complex aspects of diabetes care, the management of the diabetic foot. This is not just a matter of treating wounds, it is about preventing one of the most common and devastating complications for people with diabetes, which is the loss of a lower limb. Effective diabetic foot management requires a proactive, multidisciplinary approach, and focuses on preventing problems before they start, as well as treating any active issues that arise. At the heart of diabetic foot complications lies a triad of underlying problems: nerve damage, reduced blood flow, and infection. These often occur together, setting the stage for serious foot issues. The 4 pillars of diabetic foot management. Let us break down diabetic foot management into 4 essential areas: prevention and screening, relieving pressure, wound care and the removal of non-viable tissue, and managing both infection and reduced blood flow. Prevention and screening, the cornerstone of care. This is truly the most effective strategy. The guiding principle is simple: examine the feet at every visit, every time. Patient education is essential. Individuals with diabetes should be encouraged to inspect their feet daily, checking every part including between the toes for cuts, blisters, redness, swelling, or nail problems, using a mirror if needed. Proper footwear is also crucial. Never walk barefoot. Instead, wear well-fitted, protective shoes with soft insoles, and break in new shoes gradually. Good foot hygiene involves washing feet daily with mild soap and lukewarm water, and drying thoroughly, especially between the toes. People should avoid self-treating corns or calluses, and never attempt to cut ingrown toenails themselves. Regular foot examinations by a healthcare professional are important for all people with diabetes, at least once a year, and even more frequently for those with a history of ulcers, amputations, or other high-risk factors. Screening for risk factors includes checking for nerve damage with a special pressure test, assessing for poor blood flow by feeling foot pulses and calculating the ankle-to-arm blood pressure ratio, and looking for structural foot changes like Charcot foot, bunions, or hammer toes, which create areas of high pressure. Relieving pressure, no offloading, no healing. It is impossible for a foot ulcer to heal if it is constantly under pressure. The gold standard for relieving pressure in plantar foot ulcers is the total contact cast, which redistributes pressure evenly across the foot and leg. Removable walking boots, such as pneumatic walkers, can also be effective, though success depends on whether the patient wears them consistently. Therapeutic footwear, including custom-molded or extra-depth shoes with pressure-relieving insoles, is recommended for long-term use in high-risk patients. In some cases, crutches or a wheelchair may be necessary for non-weight-bearing, though these are often impractical for extended periods. Wound care and removal of non-viable tissue. Creating an optimal healing environment. Removing dead or infected tissue is the single most important intervention in wound care. This process, known as debridement, eliminates material that can increase pressure or harbor bacteria, converting a chronic wound into one that is more likely to heal. Debridement can be performed using a variety of methods, including surgical, mechanical, self-dissolving, or enzyme-based techniques. The choice of dressings depends on the characteristics of the wound, such as how much fluid it produces and whether there is infection. The general principle is to maintain a moist wound bed while keeping the surrounding skin dry. Common types of dressings include hydrogels, alginates, hydrocolloids, and foams. For wounds that do not heal with standard care, advanced therapies such as vacuum-assisted closure, biological skin substitutes, or growth factor treatments may be considered. Managing infection and reduced blood flow. Let us start with infection. Diabetic foot infections are medical emergencies and are a common reason for amputation. Diagnosis is based on signs like pus, redness, warmth, tenderness, and odor. It is important to note that not all ulcers are infected. Obtaining deep tissue cultures after debridement provides the most accurate information. Antibiotic therapy should cover the usual bacteria, including resistant strains, and severe infections may require intravenous medication. However, antibiotics alone cannot reach areas of dead tissue or abscesses. Surgical removal or drainage is often needed. When it comes to reduced blood flow, or peripheral arterial disease, no wound can heal without enough blood supply. Non-invasive tests, such as comparing ankle and arm blood pressure or using ultrasound, help assess blood flow. If significant blockage is present, referral to a vascular surgeon is essential. Options for restoring blood flow include angioplasty, stenting, or bypass surgery. Special considerations. There are two special situations to keep in mind. The first is the Charcot foot, a destructive process affecting the bones and joints in a foot with nerve damage. It is often mistaken for infection and presents with a warm, red, swollen foot but usually without a wound. Management focuses on immobilization and strict pressure relief to prevent deformity. The second is bone infection, which is common in chronic or deep ulcers. It can be diagnosed by probing to the bone, using magnetic resonance imaging, or taking a bone biopsy. Treatment often involves a combination of prolonged antibiotic therapy and surgical removal of infected bone. The multidisciplinary team approach. The key to success. No single specialist can manage diabetic foot complications alone. The ideal care team includes a primary care physician or podiatrist for prevention and initial management, an endocrinologist for glucose control, a podiatrist or wound care nurse for debridement and dressing, a vascular surgeon for revascularization, an infectious disease specialist for antibiotics, an orthotist for custom footwear and offloading devices, and an orthopedic surgeon for complex reconstructions or amputations. Summary and clinical pathway for those with a high-risk foot due to nerve damage, deformity, or poor blood flow. Prevention is the priority, including education, custom footwear, and regular team-based assessments. For neuropathic ulcers without infection or poor blood flow, the mainstays are pressure relief, debridement, and moist wound dressings. Infected ulcers require cultures, antibiotics, and urgent surgical action. Ischemic ulcers, those with poor blood supply, call for prompt referral to vascular surgery, as wound care will not work without restoring circulation. If a wound is not healing, reassessment is needed to check for inadequate pressure relief, ongoing infection or bone involvement, uncorrected poor blood flow, or poor nutrition, and advanced therapies should be considered. Conclusion. In summary, managing the diabetic foot is a continuous cycle of risk assessment, patient education, and aggressive, multidisciplinary intervention at the first sign of a problem. The ultimate goal is always the same: to preserve a functional, pain-free limb and maintain a high quality of life for every patient. Thank you for tuning into this important discussion on diabetic foot management. Thanks for tuning in. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.